Next from Springfield, Representative Rodney Davis is joined by several doctors and healthcare practitioners to discuss what the spread of Ebola means for Central Illinois and its healthcare facilities. This runs about 1 hour.
Specifically have treated the late Thomas Eric Duncan. We as policymakers have to make decisions based upon what we see in the media, and instead of just relying upon the media reports, I wanted to hear from the experts here. I saw the president yesterday remind the American people that the odds of getting Ebola are very low. I want to make sure that you have everything you need to keep it that way. And I want this to be less a discussion about what could possibly happen with an outright Ebola infection globally, but I also want this to be a chance for you to let us know and let the public know what it is Ebola means to Central Illinois and Middle America, and what the options are, and what the chances are. Because I just saw a poll on the way up, 46% of the American people believe that their government is hiding something from them on Ebola. This is a chance to let the constituents of this district understand what Ebola means to Central Illinois and what it means to your facilities. I do want to introduce my wife, who's sitting in the back, Shannon Davis. This meeting was called because I saw the young nurse who was treating Mr. Duncan got diagnosed with Ebola. My wife's a nurse. My wife trains nurses at Memorial Medical Center. I want to make sure that no nurse has to go through what these young nurses are going through. And it's not just about those who are going to be traveling. It's not just about those who are flying out of the infected countries. It's about those caregivers who are, by their job duties, tasked with treating those who are infected with this deadly disease. And we need to make sure that those nurses are protected and that the right protocols are coming from the CDC to ensure that we do not have any other infections. So I'm here to listen to you. I'm here to talk about the issues, hear from you. I'd like an open debate and discussion. I would first like everyone to go ahead and go around the room and introduce yourself and where you're from. And again, thank you very, very much for being here. This is a meeting that I didn't expect to have, but it's a meeting that, as your congressman, I'm glad to be able to help coordinate and help get the message out. So,
okay, thanks. Good morning, everybody. My name is Kathy Grossi. I'm a VP at the Illinois Hospital Association for the Institute in Innovation in Care and Quality. My background is in nursing. I'm also an attorney. I've been with the association for 15 years and function in the role of being an advocate on behalf of our 200 hospitals across the state of Illinois. And it's always put me in some very interesting dialogues and conversations, but they are very, very important because, as I've learned over the years, what we're dealing with in real time truly benefits from a lot of mutual conversations or the interaction of various interests to realize the right care that needs to be delivered at a point in time. It isn't just one venue or one discipline, but it's really how we're all working together. And certainly that has never been more of a challenge than with the evolving events as they're playing out even now as we might be in this room. So I'm appreciative of learning from you all today as much as being here and sharing our perspectives. So, thank you.
thank you.
Good morning, everyone. My name is Jim Stone. I'm the Director of Public Health for the Sangamon County Department of Public Health, and we're also responsible for Menard County as well. I've been in this job for 25 years, and we've had incidents in the past where we've had to bring the community together. We've had vaccine shortages for a flu vaccine back in 2005. We had the H1N1 situation back in 2009. Going back a ways, we even had a meningitis outbreak. We had to deal with that. And so this community is very good about coming together. Over the course of the last few days, we've been in touch with both hospitals, chief medical officers, the chief judge for the Sangamon County Circuit, as well as the state's attorney, Springfield Fire, Springfield Police, Sangamon County Department, Sheriff's Department, and all of us basically just getting on the same page. We will continue to do so and actually pull together and share guidance documents that we get from the State Department of Public Health that obviously will be coming from the CDC. Congressman, I thank you so much for having this meeting today, because while we work so well here together locally, it's important to have this federal touch, if you will, that you can bring to this, and making sure that we are being heard back at the federal level through the CDC is extremely important because we rely on them very heavily. Thank you so much for everything.
My name is Karen Trimberger. I'm a nurse and I'm a master's in public health. I've worked at Memorial for 31 years, but I've been in the infection prevention role for 8, and I'm the assistant director for Memorial Health System in infection prevention. Thank you.
Hello, my name is Jessica Barkley. I am an RN and I'm the infection preventionist at Carlinville Area Hospital and New York Critical Access Hospital, about 45 minutes south of Springfield. So interesting to get our critical access representation here.
I'm Julie Moore. I'm the Director of Community and Government Relations at Decatur Memorial Hospital, and all of our infectious disease people are working on this indicator, but we've been in meetings and on the phone for days. I think we've got a pretty good policy and protocol in place, but the main thing is for all of the hospitals and health agencies to work together because it is crisis level.
Thank you, Julie.
Good morning. I'm Marsha Prager. I'm the Chief Nursing Officer for Memorial Health System here in Springfield. They're based in Springfield, North, 3 other hospitals and primary care clinics, and we have over 5,000 employees and treat 150,000 patients in our clinics. So we have a lot of work to do across the continuum, and again, just as Jim said, relying on the CDC and the guidance as far as an evidence-based approach when there's so much rumor and hysteria and overinterpretation of what needs to happen is very, very important right now, and that's something that we would really appreciate you getting back to them.
Thank you, Marshall.
I'm Bob Scott. I am the Vice President and Chief HR Officer at Memorial. I am without a blue card. Bob Scott is easy to, yeah, I'll put mine on there. And Congressman, we share a commonality. I was born of a nurse and married to a nurse.
It's the only reason we hired him.
That was the end of the interview. I was in. I appreciated your comments with regards to healthcare workers and the concern that they have and the thoughts that they must be going through. Because the great thing about healthcare workers is they have this passion to want to make a difference. And we have an obligation to make sure that they can safely make that difference. And so when you ask the question about let's make sure the federal government is aligned, that would be my interest in the discussion, that they understand that challenge and that they're organized around it.
Thank you, Mr. Scott. I appreciate one HR decision you made of the 5,000 nurses that are hired at Memorial.
The best nurse in the place, except for the one to my left.
Thank you very much.
I'm Kelsey Gursky. I'm the Director for Public Relations at Memorial, and our audiences are both our employees, so we do a lot of internal communication, and then we also are responsible for being Memorial's voice out in the community, so I'm here wearing both hats and just figuring out what we can do to best serve both of those audiences.
Thank you, Kelsey.
Good morning. My name is Melissa Black. I'm the Manager of Government Relations for Carl Foundation Hospital and Physician Group in Urbana, Illinois. And we have both the ambulatory side and our level 1 trauma in East Central Illinois. I am the full contingent for Carl for right now because all of our infection prevention folks are busy. We're actually hosting town halls today and tomorrow for all of our rotations at Carl. And so they're busy getting ready to do the hands-on and having these same internal discussions as well. So I appreciate the conversation today, and we'll be bringing my notes back.
Excellent. Thank you, Melissa. AJ?
Congressman A.J. Wilhelmi with the Illinois Hospital Association and with my colleague Kathy Grossi. Really just want to thank you for convening this discussion. It's really important that we have these meaningful, thoughtful discussions, keep calm, and take the right next steps to make sure that we're all ready, if necessary, to address this very important issue. And so on behalf of all of our hospitals, certainly those here, and appreciate all the representation from the Illinois hospitals here in the room, but across the state, the Illinois Hospital Association is working day and night to make sure that we are a resource and that we're helping to make sure that we take those right next steps. And our hospitals are ready in the event that they need to be.
Thank you.
Thank you again.
I'm Nora Washburn, RN. I'm Inpatient Services Manager at Payne Community Hospital, another critical access hospital 45 miles southeast of here. Infection control is one of my duties, and it's nice for our size hospital to be here because we are kind of little, but with the travel today, we could get something we wouldn't know what to do with.
Thank you, Nora.
Thank you, Congress. My name is Gurpreet Mandal. I'm the Chief Medical Officer of St. John's Hospital, which is the flagship hospital for the Hospital Sisters Health System, which, as you all know, is a 14-hospital system. By trade, I'm a pediatric intensivist and still practicing. So have significant concern about the ill ones and pregnant women. And I'm very thankful for you for putting this group together. I do anticipate some of my other partners and leadership members will be here soon representing the system. But I think in dealing with a situation like this, a collaborative approach is extremely important, and I'm thankful for everybody who's here. I think moving forward, we can do more together than as individual hospitals, institutions, and organizations. Thank you very much.
Thank you, Doctor.
I'm John Quirala. I'm with S Medicine. I'm Professor and Division Chief of Infectious Diseases. And I mean, it's nice to have a group like this, and thanks for doing this, because as Dr. Manders has said, it's very important to have a committee-wide effort, and I think we should be having more group meetings and doing things together to face Ebola.
Well, thank you. Thank you very much, everyone. And I like the fact that we're represented by some of the critical access hospitals that I'm blessed to represent in this district, and some of the largest hospital systems that are in this district, because it takes that whole community of care, as we heard from each of you, to make sure that everyone's prepared. I do want to introduce Ashley Phelps. Ashley is my healthcare legislative assistant out of Washington. She came back for this. She stands ready to assist in any of your efforts in making sure that the messages that are given to us today and get back to the CDC and in other federal agencies too, like the FAA. A week ago, I sent a letter to the CDC and to the FAA that asked them to lay out some procedures that they were going to follow and protocols that they were going to follow. Obviously, there's been a lot of discussion in the last couple of days on whether or not to ban travel from the 3 most affected countries in West Africa. That's something that I would hope that we could discuss here today. I know there's been some information put out into the media that somehow CDC funding has been cut. I will hopefully take care of that dishonest fact right now. CDC funding last year was increased by 8%, and 88 million in additional funds were put forth before we left Washington just a few short weeks ago, just to address Ebola. So the funding issues should be there. We need to make sure that the policies and the protocols coming out of those same agencies that were funded and tasked with this effort are actually put forth in a manner that's going to assist you on the ground. I would like for discussion points to center on those issues too. I know that the House Energy and Commerce Committee is holding a field hearing on this same issue today. That would be more of a hearing of witnesses coming in front testifying. I don't want that. I want to hear from you what concerns you the most and what you need. So let's go ahead and start the open discussion. I'm probably going to put the 2 doctors on the spot, because I'm going to ask them to start to at least let us know and let the public know what is the chance that Ebola will come to Central Illinois, and if it does, what are the chances of infection?
By the way, Dr. Govindaya is the CMO.
Hey.
Hey, Rodney, how are you? We've actually met before.
You snuck in on me.
Right.
I apologize.
Oh, no, that's all right. That's all right.
Just wanted to clarify that we have a 3rd doctor in the room too.
Thanks, Don.
So I mean, I can start to talk about what are the chances of having Ebola in Central Illinois. I think until recently, until the Dallas incident happened, we're thinking that's the problem of West Africa, and it's been there in West Africa since 1970s, so we know about it, and it has been contained very well with the WHO and all other agencies that are involved. But as we know, the world is connected together by airlines, and people are traveling. So there was always a fear, and that fear was actually it turned out to be reality when we saw the case in Dallas. So I think our focus should still be at the place where it is mostly affecting the West Africa, and I think if we do a good job, of course at the federal level and at the airports and things like that, then probably the chances of importing the virus can be reduced. But now, since we know that there's already a couple of people infected within the United States, I think we have to be more careful. So I think it requires a joint effort for us as a community in the central Illinois that if somebody, a suspect, let's say a suspect who might be flying from either West Africa or even from Dallas for that matter, probably we should have a system where how to handle that patient, how to, or not even patient, the person may not have developed symptoms yet, how to identify those people and how to send them through the system in the correct manner without exposing too many people. So at the same time, I don't want to say that we should be having fear of everybody who is coming from Texas or something like that. But if there is a question, we should have a system where we can direct that person to a proper channel without exposing too many people. And that's what we are working together with the hospitals and the Department of Public Health.
Thank you.
Yeah, I think I can just add a little to that. I won't contradict anything the infectious disease expert says, but more from a process perspective, we're not immune to exposure. Given the travel is definitely one issue. The other is we have people from different backgrounds settled in central Illinois. So I think people should be cautious, prepared, but not panicky as such. The odds of a full-blown epidemic, most of the experts say, are low, but yet we have to be prepared thereof. I think the biggest issue is for us to be prepared to deal with an eventuality. And that lies in education and preparation, which I believe most of us are doing. But we need more information from the CDC. I think one of the key issues has been the confusion around the protective equipment. And many of our healthcare workers, as we train and drill and do other things, come up and ask us that when we see those videos from Africa, they wear the full protective gear, whereas the initial recommendation which came out from CDC was to use standard contact and respiratory precautions. And this is a much more involved protective method. And it seems after looking at these two cases, there may have been a breakthrough, could have been an individual error, we don't know the details. But when you have two cases, it brings up the question of whether the providers are safe. And I think one of the first things we need to do is make sure that healthcare workers feel safe in providing care to anyone who is suspected or proven Ebola. The other thing which I brought up earlier was I haven't seen too much in the form of guidelines for pediatrics. May not be different, but specific reference to that, and Jenna, correct me if I'm wrong, and also with respect to pregnant women and neonates. So hopefully, as things move along, we'll get some more clarity and direction in that situation.
Those are excellent points.
Thank you.
And did you want to add, Doug?
Yeah, sure. So I think in many ways, part of the response to this is local, right? The environment that allowed this to occur in Dallas is related to the population that exists in Dallas. So Memorial Health System has 4 hospitals. Interestingly, the hospital in Jacksonville and further rural Illinois, Beardstown, they have a larger community of West African individuals than we do here in Springfield or in perhaps other parts of your district. So they have taken preparations that are in advance of what we have done because they've assessed their local community risk to be higher. So I think every community, every hospital is struggling with what are the right guidelines. We've implemented all of the guidelines that the CDC recommends. But the question we're asking is, are they sufficient? And that's really what we need clarity on. And there's 5,000 hospitals in this country. And the last thing we want is 5,000 different approaches on how to tackle this. So that's really our challenge and our ask of the CDC. You tell us what to do, and they have resources that we don't have. You tell us what to do, and we'll do it. And, Jim Stone and I, in his role of Sangamon County Department of Public Health, we had a conversation yesterday, and I know that Jim's working on putting together a collaborative effort for the county. But our biggest challenge is we're operating with a little bit too much unknown. And I understand the CDC is as well, but they're the content area experts. We need their expertise. We need clarity. I don't know how long it would take for a Ebola test to be returned to me if I draw it on a patient. I need to know that. But once the patient's positive, I need to be able to know, well, is the CDC going to accept them? Or are they going to send people to Memorial or to Springfield or to wherever to manage those patients? So similar to the guidelines that Dr. Mender was speaking of, we need a little bit more clarity.
More clarity. This is exactly why we had this meeting. Dr. Mander, you talked about protocols for treating the patient in Texas were not similar to the protocols for treating patients in West Africa. And we need that, as you said, Dr., clarity and concise information as to how the protocol should be followed, especially for personal protective gear. Because do you, as hospitals, have enough personal protective gear?
We placed an order yesterday. We spent about $75,000 to get what we think we need right now. But
$75,000 for what you think you need.
and what we believe based on CDC guidelines. But that begs the question, will there be enough for every hospital across the country? We don't know what the supply is, and it was expensive.
Well, then the questions of having a community-based resource for this, so we can kind of control that and distribute as needed.
And along that, what I've heard from some hospitals, it's been presented to the association in the sense of, do we want to use the one suit with the attached hood and the feet, and if we do that, is there enough supply? Because we've seen that those practitioners that have to interact with any active case, that's their preference versus just a gown, mask, and face shield. So that's where there's some inconsistencies, and then a sense of how robust is that supply chain, and can it be active enough to supply all the needs ongoing, especially for our two hospitals in Illinois.
So I can clarify a little bit on that. If somebody is a suspect who is being seen at a clinic setting, then all you need is the standard, what we call in healthcare, people will understand the personal protective equipment, which consists of a gown, gloves, mask, and face shield. That's all I recommend. If there is any chance of any spill or contamination, then you might want to wear the shoe cover also. But because those are only casual contact examination and things like that, so that's all it's needed. But if a person is, diagnosed with Ebola, or let's say they are highly suspicious for having Ebola just from the clinical assessment, and that person is having bleeding, have secretions, things like that, and a nurse is taking care of them, changing the clothing or cleaning the patient, and they are the ones who have to use what we call as hazmat suit, which is the whole garb with the double gloving and tape and all those things. So I think that's necessary if a person is diagnosed with or highly suspicious for Ebola, and somebody has to be in the room for a long time, like in the hospital setting, which is not necessary for the clinics. So, but I think we should have both in stock, and that's one of the things that I think the CDC is not clear when to wear one versus the other. They are telling us to wear the PPE, that's the regular PPE, which is not sufficient if you are involved in patient care in the hospital.
And that's
so the
currently-
guidelines are not quite clear.
That's currently the guidelines that you've been given from the CDC, is to use just the normal personal protective gear.
Yeah, the question which I have is that has the CDC reached out to Doctors Without Borders and some of these organizations who have been working with Ebola for decades? They have more experience in this than probably anyone in this country, probably including the CDC, in the practicalities of taking care of such patients. And probably they have or have not, but I think there's a lot to learn from these organizations.
Well, we will, and this is why we're here, we'll take these suggestions and we'll actually draft a letter to the CDC asking them if they have consulted with Doctors Without Borders, if they have given better guidelines for personal protective gear. This is exactly the reason why we wanted to have this meeting today, as to how we can be the advocate to reach out and get your concerns known. Anybody else want to address the guidelines? Marcia?
I just would like the CDC to move ahead with their decisions on how we're going to resource this, whether it's going to be every hospital's expected to be able to be Ebola, treatment centers, or whether there's a regional approach or someplace that there's going to be patients centralized in a particular area. These patients are incredibly hard to take care of, intensive, and every hospital, even our hospital, it would be a stretch to have the kind of biocontainment unit, facility, staff, education, awareness to be able to run these patients. I mean, these patients are extremely sick for a long time. So they keep saying they might go to a regional approach. They might say everybody's going to go to, one of the biocontainment units in Nebraska or Emory, but they really haven't said yet how that's going to be managed or whether that will be managed in a recommendation and whether they're going to accept patients from all over the country to do that kind of approach. But I think the idea of them sending a response team to us has some merit, but they don't bring the resources with them. And
Could the hospital association do us a favor, reach out to Rush and reach out to Resurrection and see if they've been given different protocols, since they are going to be one of those treatment centers that have been designated for the increased screening process at the airports. Obviously O'Hare is one of the airports that makes up a few that 94% of all the air travel from the West African affected countries comes into. So if you guys could do that and share it with the rest of the group, would be great. And if not, we're going to continue to ask for better protocols. And you're right, Doctor, pediatrics, pregnant women. We think about Mr. Duncan. Mr. Duncan is in West Africa, and he did exactly what all of us would do. He helped the young pregnant lady who was sick and carried her. Human kindness should not be, we should not get away from that. And we need to make sure that we do everything we can at our level to stop it.
Yeah, just another comment. I think people need to understand that even if we do regionalize the care of these patients, hospitals still need to be prepared to evaluate, stabilize, and transfer.
Yes.
And so we need to be cautious about that fact.
And that goes back to knowing how long it's going to take to get a test, because do I hold and wait for my result in our ER, or is this patient going to be someplace for 48 hours while I'm waiting for a test result until I know whether the patient needs to be transferred? I mean, some of these unknowns are very hard to plan around as to what I'm going to do in my emergency department if I have a patient that actually makes it through the algorithm and needs to be tested.
Could I go back to the personal protective equipment?
Yes,
One of the
ma'am.
things that I would like to see as a practitioner is the very concise language for the personal protective equipment. Because some of the publications that have come out have said load-resistant gowns, then it was changed to impervious. Well, what exactly does that mean? And we've done further research to determine what that means. And a type 2 gown versus a type 3 and 4, it would be nice for someone to say, instead of impervious, or is everyone purchasing type 3s and 4s, or do they have type 2? Things along those lines, because you've got all these hospitals preparing. If they think they only need an isolation gown, they're not going to have the right level of gown to protect them from a healthcare worker standpoint, and that's my concern. You've got all these people doing something, just like you said, Dr. Govindaya, tell me, purchase a type 3 gown, this is what you're going to need, I'll do it. But don't just say impervious gown and leave that up to interpretation. So along with the same thing with the Tyvek suits and things, tell me what level, because there are certain ones, there's a different variety of those model numbers where the seams are not completely sealed and different, they're sealed, but there's certain things that have to be done in order to make it impervious to this virus. So tell me the one to order. That's what I want you to do. Don't say there's all of these in the marketplace or a Tyvek suit.
Give us the guidance.
Yeah, all I want is concise, because when you're running around trying to put protocols into place and things like that, and when all the hospitals are doing the same thing, how nice would it be to say, oh, I need a type 3 gown, I need a nitrile glove, I need this, I need that, boom, bam, okay, I'm on my way. Instead of us doing experiments on a gown to determine if it's impervious or not. That's what I did. I had nurses putting fluid on a gown to determine that our gowns were type 2, not type 3, and we needed 3.
And adding to that,
So.
one of our, thank you. Adding to that, one of our top concerns that our folks have is, will there be online video demonstration from the CDC? That's something that we would like to see. So we would roll into our training, because we're doing constant training and how to set up screenings and protocols. But if the CDC can do something that is a visual online that we can share widely, we would encourage that.
Yeah, because we're looking for that same, how to don the
Tyvek suit
On
and how to
and
take it
off.
off, because they're saying that it's the removal
Yeah,
that's
what is the
that's
best
worse.
practice to
Yeah.
use this equipment that we don't use every single day?
Show me how.
Right. So Shannon can then take that information and help me train all the nurses at Memorial, because that's the piece, that's the unknown. How do you take it off safely? I mean, we think we know, but it would be nice to have the guidance from CDC that says this is how you remove it.
And two things with the guidance. One, they've started using observers in Texas to make sure that the
Yes,
protocols are used
yes.
properly. But then secondly, we're talking about the utilization of these PPEs. I know that there have been times the federal government has talked with vaccine companies. It's probably good to network back with medical supply companies to see what our supplies are.
Yeah.
The ability to regenerate these items and how quickly they can be pushed out to those healthcare facilities. I would not doubt at all that you have healthcare facilities somewhat speculating right now on buying what they can because they know that there will be a surge for this equipment and then it'll be gone.
And they're buying the wrong thing because
Right.
we don't have the clear
Right,
guidelines
right.
about, a face
Right.
mask is not a face mask,
Right.
it's not a face mask.
Right.
And there's hundreds of vendors out there, they'll
Right.
sell you anything and everything, and if you buy the wrong thing, you're spending a
You're
lot
not
of money
protecting
on
your
something
worker.
that you have
So-
a false sense of security and your poor caregivers are not secure and not safe.
It comes back to, we're all committed to doing the right thing. Just tell us what that is.
Yeah, I think that encompasses
Clearly.
environmental issues too, because different communities, I don't think they know what to do with the waste. And also with regards to a simple thing like, do we flush the toilet, do we not flush the toilet after putting peroxide in? How much peroxide? The guidelines of, there are some guidelines out there from CDC on what to do with this, but they're not clear. And secondly, different communities I've heard have decided differently on how to deal with the simple aspect of flushing the toilet after the decontaminant is put in.
Well, in the absence of facts,
Yes.
people make things up, and that's getting more and more confusing to the public, and it's getting confusing to caregivers, and all these mixed messages is just raising the anxiety level and the perception that the healthcare community doesn't know what we're doing. And that's a really troubling thing when they need healthcare services, and they shouldn't be hesitating going someplace to get help, and our caregivers who want to give help are safe in doing that.
Congressman, you know better than anybody, politics is local. And fear is local.
It is.
And local looks to the people you have around the table and others in this community to help allay that fear. And I think what you're hearing is this, we need that information to be able to keep that fear at bay and help educate the public.
And that's exactly, as I said in my opening remarks, why I wanted everybody here today. I will tell you, I was kind of hoping that the CDC would have been offering these protocols to you already, and it's very frustrating to me to hear that there are too many issues. Precise instructions for protocols. What type of PPE? Something as simple as an online video. These are simple requests of the CDC that we will make, and this is, again, exactly why I wanted to coordinate this roundtable, because there are too many unanswered questions. I want to open it up. I've led some issues. Are there any issues that you came here today thinking you wanted to discuss on this topic that we have yet to address?
Can I elaborate from our critical access standpoint? We feel mostly prepared to identify a patient that would come into our emergency department and to do the initial PPE, which we're hoping from a critical access standpoint, they're going to be early on in the disease. However, it's very unclear of how we would transfer, who would accept the patient from us. It's under my understanding we would call IDPH and they would assist in that, but there's no guarantee that someone's going to accept that patient out of our facility. And how do we transfer them? Are EMS personnel going to feel comfortable transferring the patient to Memorial or to St. John's from Carlinville? So that's very gray for us. We would not be able to keep a patient as they progressively got worse in the critical access hospital. So that needs to be a clear pathway. We could be planning that ahead of what that protocol is going to be.
No, that's a very, very good point to make, Jessica. As a matter of fact, I mean, you know as well as I do how important critical access hospitals are to our entire medical community. And for those in the media and those who may not know what a critical access hospital are small town hospitals like Carlinville and Pana and my hometown of Taylorville. And these are issues that aren't just tertiary issues. It isn't, oh wait, somebody's coming in, how do we get them to a larger facility that may be more prepared? These are facilities that are crucial for providing the initial medical treatment for all types of illnesses and diseases, and then feeding those most sick to the larger facilities, Memorial or St. John's, etc. We have local ambulance providers who are going to ask these same questions, just like you said, Jessica. Local nurses are going to be just as concerned as to whether or not Taylorville Memorial Hospital or Carlinville Area Hospital is going to be prepared to make that. And these are questions that need to be answered now so that we don't have to wait until it happens, if it ever does. And we ought to be more proactive, because these critical access hospitals, they're not just medical facilities in our small towns. They're our largest employers. They're our local economy. This is crucial to make sure that they understand that they need to be successful. So thank you for your comments too, Jessica. Dr. Mende.
Yeah, I think another thing I want to bring up is that the representation across this table is predominantly hospitals and large hospital systems which have adequate resources. I am not sure how prepared practices, small, large, and practice groups are to deal with this, because I believe more patients seek care in clinics and outpatient facilities than they do in the hospitals. So I think there needs to be a focus on that population too, and that folks too.
That's a very good point. The small clinics, community health centers. You know,
Right. So to that point, one of the most important things is just similar to if a critical access hospital screens a patient. Well, what if a primary care physician screens a patient? And how do they transport that patient from their facility to my emergency room or the emergency room at St. John's to be assessed further? And what protocols do we put in place? What communication exists? And all of that's got to happen at a local level. But some overarching guidance as this is best practice, here are the things you must do. So we're in the process of making sure that patients are notified when they encounter any point of care in healthcare through Memorial Health System, whether it's in the emergency room or through our front door or in an express care or in a primary care physician's office, that they're asked simple questions that heighten our awareness if they're at risk, so we can then screen them appropriately. And there are 2 large physician groups in town, and I've talked with representatives of both of those groups about adopting a similar approach. And I'm confident we'll be able to do that. But then once they've identified someone in an outpatient clinic, how do they get them to the right setting of care?
Very good points.
And kind of an add-on to that, we have the issue of contact tracing. And we're getting questions from law enforcement if we have to utilize isolation and quarantine, where I have the authority to place a law enforcement officer at somebody's door. They want to know about PPE. What do they need to use? What's their level of force that they can use to actually enforce isolation and quarantine? I've been in touch with IDPH. We are supposed to be getting guidance perhaps today or tomorrow on that, but that's one of the reasons why we're waiting to get everybody in the room together, because we want to have everybody hearing the same message with the same guidance. And think about the most innocent of contacts. Well, yes, I was there, and then that's where it starts, to happens to live next to a law enforcement officer who has a buddy who's an EMT, and on. You can imagine just how it goes. So that's how this word travels, and most definitely focus needs to be on the healthcare facilities, but we have to think about just how any and all options that somebody might enter the system that would need to either be H&P, contact tracing, or isolation and quarantine.
Well, I can tell you I'm learning a great deal. As a policymaker, I'm probably a lot further away from where we need to go at the federal level than I thought I would be. There are a lot of unanswered questions that still need to be addressed by the CDC and our federal officials, and I'm going to make sure that we ask them to address each and every one of those issues. And one issue in particular I want to throw out for discussion, and it actually comes up based on some of the points you made, Jim, which about contact. You know, it's being discussed right now, at least reported, that those who took care of Mr. Duncan in Texas are being put on a no-fly list. While at the same time, it seems our federal officials are hesitant from stopping travel visas from the affected countries. To me, that doesn't make sense. We need to make sure we get a better handle on this issue and how prepared we are at all levels before we continue to allow travel visas from those most affected countries. I know we have screening processes in place. I know we have voluntary checks in boxes on forms of whether or not somebody has traveled to those areas. It obviously did not work with Mr. Duncan. I'm going to call for travel restrictions from those countries as the chairman, the vice chairman of the aviation subcommittee. It's an issue we're going to continue to press on, because even after we've had this discussion, I'm even more in favor of doing so, because there are so many unanswered issues with just specific protocols within our largest medical facilities here in Central Illinois. So I'm happy to have anybody discuss, debate, give me if I'm right, if I'm wrong, or if it's simply something we just have to do, please.
I think the incident of the nurse on the Cleveland flight, when you think of 132 people and how many people, those people, it was a very quick lesson in how quickly something can get out of control when you have these mass crowd effects with an innocent person who didn't realize, I'm sure she didn't realize that she was sick at that point in time. I don't think any nurse would take anyone's lives in their hands and say, I'm going to, irregardless, do what I want to do. I just don't believe that. But she thought she was okay until she got home. But when you see 132 people and they all went home to 132 people who went home to 132 people, you can see how quickly this Pandora's box can be out of control. And that, I think, it was like a whole new ball game to us yesterday when you really saw that. I was like, okay, new game changer. So I think that the understanding that when you allow people in public places to innocently impact other people's lives and how quickly that can snowball, I think we have to be very careful about those decisions and make tough ones.
Thank you, Marcia. And Jessica, when we were talking a couple days ago at your groundbreaking at Carlinville, I never anticipated what would have happened yesterday that Marcia addressed. So it's very good to hear. I want to keep this to under an hour. I know we're winding down the time. I want to throw out any closing, opportunities for you to bring up any subject that we haven't addressed.
Just one comment on education. Are we doing enough to educate the public? Because I see that as the first line of defense. An informed public, informed patient population, and community is probably the first line of defense in this.
Reliable education.
Right.
Yeah.
So they're not so scared. I think the panic, gets into their voices. Do I get on the plane? Do I want to go to Dallas? I think the reason stops because they start getting so scared.
Yeah. So, as somebody who flies on airplanes a lot, not first class.
It wouldn't help you anyway.
The air is the same.
Yeah, the air is the same.
And that's a question for you, Doc, is those passengers on that Frontier Airlines flight, what is the risk?
So actually, it's not a risk unless you're sitting next to the person and got contaminated with the secretions.
Okay.
That's the only risk. It's more like, so it has to be within 3 feet when the person is coughing or sneezing, or some secretions that, got contaminated. You have to be contaminated in the mucous membrane, so eye or mouth, or if there's a cut or something like that, then that's the only chance.
So the
Rest of the
chances-
people, just because of the air exchange, should not get it, so
Okay.
it's not that contagious.
The chances are extremely low.
Chances.
So, good.
I would fly.
Just don't use the bathroom.
So I have more comments if you need a second.
Yes.
I think this also creates a human resource issue for organizations as to what to do with our partners and our colleagues who take care of these patients. There are questions about whether they need to be kept in the hospital for the duration and thereafter. I mean, some organizations have talked about that, or can they go home? There are concerns about their children thereof. And also support for the families of the suspected patients or patients. We need to make sure they're not stigmatized. Because I think that might happen unless we educate people properly about this disease and how to manage it. So we need to be careful about that.
Very good points, very good comments. We've got about 5 minutes left. Happy to,
One question that I was sent with was whether ZMAP or any of the investigational drugs, if you can get a clear answer that's maybe not in the media, but a clear answer on whether any of those investigational drugs are going to be made available or could be soon made available.
that's a question I would ask.
Yeah, as far as I know, the ZMAP is out of stock because it takes a long time to grow. It has to be grown in tobacco leaf and it takes months to grow. But there are other, I mean, the only thing that we have right now is the transfusion from people who are infected and recovered from infection. That's the only treatment. The rest of it is supportive care.
Okay. Thank you.
Oh, she's a doctor.
Hey, yes, ma'am. Come on up. Say, tell us your name, too.
My name is Vidya Sundaresh, and I'm with the Division of Infectious Diseases.
Thank you.
Can I
Come on up
just,
to the table. You're
So we
fine.
can hear you on the microphone. Or go up there.
So I had a comment about people traveling from African countries, which are really not the highly affected African countries, but some of the neighboring countries. We don't know how much of how well they've been able to contain this just to those countries which are affected.
Right.
So we encountered with someone who had traveled from Africa, but not quite those affected areas, but somewhere nearby. So the only screening modality that was used was a check of temperature for this patient before traveling. So I was wondering if there can be an expansion of screening modalities extended to patients who or people traveling from neighboring areas to not just the affected areas.
That's a very good point. Kind of a ring around that area. Okay, thank you. And please stay here, stay here. Any other issues, any other questions? We've got a table, we've got tables of experts here.
So, Congressman, I think one of the key things we all need to keep in mind is our ability to educate the public, our ability to educate the staff, is what will prevent them from panicking or drawing unreasonable or inaccurate assumptions. And right now, we feel, and I think everyone in the community has educated to what we know. The challenge we have is that some of the things that we're being told, we don't have 100% confidence in. So as we go to educate the public about, yes, Memorial or hospital X, Y, and Z has taken all the right steps, well, I've taken all the right steps that I've been told to take. But there's part of me that goes, geez, there's more steps I need to take, and I don't know what they are. So I feel like we're saying we've done everything we need to do to be prepared, but in the back of my mind, there's so much gray in some of the guidance that, yes, I've done everything I've been told to do, but I know that there are steps that are missing.
I'm surprised it's taken this long for them to come back with what were the breaches in, I mean, what happened
Right.
with Nina Pham that actually, I mean, you would think they would have been able to do some kind of quick study and observations with these experts to say, this is what happened, this is how we need to. But it's been days since anybody's really talked about that. So whether that means they don't know or they aren't yet ready to reveal that. But I think that's the kind of thing, the delays in some of the information coming forth is really frustrating because people are waiting for us to give them that guidance, and we want to keep our people safe.
They haven't
they're
had
not coming out.
Right. They haven't had transmission in Nigeria in, what, 40 days? What did they do? And why don't I know?
Anybody else?
The only other point I want to make is CDC is organizing training, but the only training I've heard of is in Alabama, sometimes in November, so I think that there's a delay. They should have more training centers throughout the country and, answer all these questions. I'm sure that there are experts who can be identified and sent for, giving training to each site, so they should have more.
I think what we need is a standardized training video that we can all use.
Then we can-
Well, I don't begrudge Alabama for wanting to increase their tourism exponentially for this training session. I too agree. It's something that needs to be much more easily accessible, and we can't wait till November. Anybody else? Again, I hope you like the free flow of the discussion. I hope it was educational. I hope that you walk out of here with information that you did not have. I will tell you, I'm personally walking out of here with a lot less information than what I thought I would have walked out with when I came here. A lot less confidence that the protocols that the CDC are putting in place or have put in place are getting to you, and they're actually adequate for your training needs and your medical needs at your facilities. We will turn around a letter to the CDC based upon the information that we've received here. Ashley, if we could get your email addresses before you leave here today, because I'd like to run those questions by to make sure that we didn't miss anything, or if there's something you thought of afterwards, so that we can compel the CDC to provide those responses and at least get them to think about the impact of simple things, of the collaborative approach that's necessary. What type of PPE? What are the protocols for pregnant women and children? And as a father, I'm very concerned by that the protocols for children have yet to be given to the medical community. I want to make sure that we get your questions and your concerns addressed. So we want to keep this collaborative approach that I want to just be the beginning of our discussion. And hopefully very soon, we will think of Ebola in America like we do the West Nile virus, when it becomes much more rare and facilities are much more prepared to deal with the issue. And I guess one last thing that I would throw out to the infectious disease specialists, I'm also concerned, and this may be something for another discussion, I'm also concerned about some of the respiratory viruses that we're seeing in young children that are leading to their deaths. Are there proper protocols that the CDC has yet to give to you in those cases that we might be able to assist in, at least bringing it to their attention so that that doesn't get lost in what's being done on Ebola?
Yeah, I think the enterovirus is, it's more well-known virus, and we do get enterovirus of other types, from time to time, so we know how to deal with it. Plus, IDPH and CDC prepared something, and IDPH has sent it out to physicians. But still, it's a new virus, and it's more we call it virulent, meaning more dangerous virus, so it can cause more harm. So that's why I think we have to be more careful with the virus. But I don't know, maybe the hospital directors can make a comment about the infection.
No, I think no additional comments on it. These are respiratory viruses we deal with on an ongoing basis, and we're fairly comfortable dealing with them. It's just more virulent, this one.
Okay, all right. Well, as a parent, I want to bring that up, not as a member of Congress, because I'm just as concerned as a dad. So thank you very, very much, everyone, for being here. I hope, again, this is the beginning of a discussion that we can keep having. And please, once you see new protocols come into place, if you're happy with them, communicate that to us so we know. If there's still things missing, let us know, because we want to make sure we get you the answers that you need and the educational opportunities that you need. So thank you all for being here today. I really, really appreciate it.
Thank you.
You're watching the Illinois Channel, an independent nonprofit corporation formed to provide gavel-to-gavel coverage of Illinois state government and other public affairs events taking place across Illinois.